Everybody wants to know how long it takes to review an FDA submission and how much money it costs. This video is specifically about how long the review timeline is for de novo. This is an important topic right now because the FDA just went through MDUFA reauthorization. So this is every 5 years, Congress reviews and approves a brand new bill for reauthorization of funds for the FDA to cover staffing and other things. It's their budget. It's based upon user fees, a large part of that. So if you want your FDA reviewed faster, give us more resources so we can review it faster. That's the philosophy. We'll give you more money at the FDA, and we'll get that from industry by charging them more for their user fees when they submit a 510K or a de novo. So we've talked about 510Ks, but how long does it take for a de novo? These are longer. They're longer submissions, partly because the FDA has to create a brand new product classification. That's what's different between a 510K and a de novo. You're asking the FDA, can you please create a brand new product classification for our device? Because either, number one, we don't have indications that are equivalent to some other product in the market. It's a new indication. Or number two, the risks associated with our device, because of the technological differences, are different. And therefore, the FDA needs to review it differently from other devices and can't look at equivalence to another device to justify the risks of that device. It could be both of these are different. Here's an example. COVID-19, we had to come up with a new test to identify this variant of COVID viruses. So what does industry come up with? They come up with a brand new IVD test. The technology is the same as other IVD tests out there for viruses, but it's different because the indication is specific to this new virus variant. So what do we have? A de novo submission. We had emergency use authorizations for a period of time, but eventually you have to get a permanent authorization. And the only way to do that for an IVD device is get a new de novo cleared. And then everybody after that first de novo is granted, then you can have 510K clearances for everything else. And they claim equivalence to that first de novo. So that's how the process works. Well, how long does that process take? How many days does it take? That's what investors want to know. They want to know because they want to know when they can start marketing this device. The problem is that when they negotiate these numbers and they come up with goals that the FDA is going to be funded on, it's based on something called FDA Days. That's not a real thing. It's something that they contrive to establish how much money they're going to get. And I don't have a problem with that. Every company comes up with metrics that are based on their own way of calculating things and don't mean anything to anybody else out there. The problem is it's misleading to people that are investors and not sophisticated and understand all the nuances of what these days mean. First of all, every single time the FDA asks for new information or puts your submission on hold because there's something wrong with it, that hold period doesn't count towards the number of days. So therefore, what they call FDA days, it's calendar days minus all the time we put your submission on hold. And those submission on hold periods could be longer than the actual review period. During the last several years, they've had refusal to accept screenings to make sure your submission is worthy of the FDA putting the time into substantive reviews. Well, that process appears to be possibly misused a little bit because I've seen 3 different RTA holds in a row, each one with a 180-day hold period. You're not supposed to have 180-day hold periods for a little screening issue, and you certainly shouldn't have 3 of them in a row. That's longer than the entire review process by a lot, and that's just a 510K. So that doesn't get included. And then you also have additional information requests at the very end of the process where you need to provide the missing data. Those I understand. A company makes decisions on the design of testing. They try to keep it as cost effective as possible, and the FDA wants more data. That I understand, and it's helpful to have 180 days in case I have to repeat some testing. It might take me 180 days to do some of those tests, but to have 3 different RTA screenings plus that AI hold, and then not include any of that in your metrics that you're publishing publicly, it's very misleading. So what are the real numbers? Well, I went back and I reviewed the data back in 2019 in preparation for a webinar. In the numbers for 2019, and these are calendar days, not FDA days, there were 21 de novos that were granted that year. The average duration of the review time in calendar days was 307 days, not anywhere near the 150 goal, certainly not near the 120 final decision target that was in the actual final rule for de novos. And the 150-day goal that they were trying to hit here for MDUFA decisions, that percentage, only 23.8% of the de novos were granted in 150 calendar days. Now, their goal isn't calendar days. Their goal is FDA days, so they might have actually hit it. They didn't, but they've never hit it, and I don't know when they will, but supposedly MDUFA 5 is going to change everything. So the numbers, 21 were granted, 307 days average calendar days, and 23.8% of them were within 150 days, and just barely. How are we doing recently? So I redid the analysis based on 2020 and 2021 data and I also looked at 2022, even though we're not through the year. Here's the data. 26 de novos were granted in 2020. The average was 301, so not much of a change there. But the 150-day percentage dropped to 11.5%. So we're not improving on average. The average is basically the same, and it's shifted so we have even fewer that are under that 150-day mark. In 2021, we had 30 granted. So we went from 21 to 26 to 30 de novos granted. So they're increasing the number of de novos that they're processing, but the average duration now is 360 days. So we're getting worse on the average duration. And get this, the 150 calendar days that I calculated, we only have 3.3%. One de novo granted within 150 days, and only by hours. Now we've got 2022 data. Now this is a partial year because we still have the remainder of October, November, and December. So it could go up by another 6 to 9 submissions, but we only have 17 so far. So we're not going to hit that 30 number likely. We're going to have between like 23 and 26 de novos granted in 2022 when the year is done. In the average duration so far, 394 days. Maybe there will be a miracle and it'll shift the whole average, but I don't think so. Another thing is the 150-day percentage. We're back up to a blinding number of 11.8%. This is not a huge improvement. This is back to where we were in 2020 with really poor numbers. The overall view here is the numbers don't look good. We're not anywhere near this 150-day goal unless you calculate everything in FDA days. And another thing that is not right about the FDA days, not only are you not including the whole periods, but you're also including all the submissions that got denied. So all the people that said, no, we don't grant, those numbers count in there too. So if we made a quick decision to deny your submission, we get credit for it and you give us more money. Does this make any sense at all? What really people care about is how many were approved in the timeline, not how many were denied in the timeline. So there's two big flaws in this. It includes hold period and it includes denials. So when you answer your investors, how long will it take your de novo to be actually granted? Better plan on something with a 3 in front of it and it's not 2 digits. So if you want to learn more about the data analysis, down below we have a link to a blog. I'm posting it today on this and includes all the data analysis and the exceptions and how I calculate it versus how the FDA calculates it. It includes links to the MDUFA 5 decision goals. It's a draft still. So there's lots of information down below if you click on that link, and it's going to be posted in the next hour. Another thing that's down below is a link for our 510K course. We lump our de novo templates and our de novo webinars in with our 510K course content. And the reason why is 80% of the content of a de novo is the same as a 510K. They even use the same template, the same eStar template. So it's only a few documents that are different. And so instead of substantial equivalence, you're doing a benefit risk analysis, for example. There are only a handful of documents that are different between the two. There's a difference in budget, there's a difference in timeline, but for the actual submission content in the templates, 80% of it is the same. So why not lump it in with the same course? Also, some companies, when they submit a 510K and then they get a non-substantial equivalence letter, so they're denied, Then they shift over to a de novo. So it'd be nice to have all that content already so you can switch gears and work on your de novo. So we've lumped the two together. Last but not least, down below at the very bottom, we have a bunch of Calendly links. So you can schedule appointments with any of our consultants that do these de novo submissions. I've done 2 in the last month. So they were at the very end of September. We finished 2. I've done several in the past, but 2 very recent ones using the new eStar templates. Bumiko Joyapa, she did one as well for me because I was overloaded with work at the end of the fiscal year. And then Mary Votter did one back in August or July. So her submission is in review. So we actually have 4 de novos that are in the review process right now. And our last one was number 71. So there have been at least 71 de novos submitted in 2022. So the number of de novos being submitted is going up in 2022. And we'll see what happens to those timelines going forward under MDUFA 5. But cross our fingers, hopefully things will improve. And in the article, click on that link for the article in the blog. I talk about ways to improve it. So if you're at the FDA and you happen to be watching my review timelines, modular submissions, really good idea. Introduce that at your next discussion. And if you're on the committee, if you're on AdvaMed or one of the other industry groups that negotiate with the FDA, modular submissions, really good idea. Try it with a de novo program. Think of it as a pilot, but it would really help. We already do it for PMAs. Why not do it for de novos? You could even have the third-party reviewers get involved, and they could review everything that's not part of the clinical data in the final decision on whether it meets the de novo requirements. They could just review the benchtop testing data and electrical safety and biocompatibility and sterilization. There's a whole bunch of things they could review without making the final decision. Think out of the box, people. Modular submissions. Thank you, everybody. And for those of you that waited till the very end, if you go subscribe for our 510K course, you get invited to our live streaming training courses. This Thursday, we're doing one on pre-stars. If you don't know what a pre-star is, it's an e-star, but it's specific for pre-submissions. And the FDA hasn't released the template yet, but they already have it validated for 513Gs, and they've already put out a discussion comment saying, hey, what do you think, industry, about doing this for all of our pre-submissions? Yes. Do more e-stars. So the pre-star may happen. I don't think they're going to call it the pre-star because it's too cool and makes sense. But that was the FDA's team's name for it. Their nickname was Pre-Star. I love it. So go Pre-Star. Next, it's actually this Thursday, and it will be recorded if you can't attend it live. But the only way you get access to it, you have to subscribe for our 510K course. So click on the 510K course link below. Thank you, and see you next time.